Welcome back, and if you're just joining us, my special guest is Dr. Tammy Grubb, as she goes by. She's a veterinary anesthesiologist who hails from Washington, and we've been talking about pearls of wisdom for anesthesia for the vet team. But, you know, anesthesia is an interesting thing, and so the question I have for you, Tammy, is it's all drugs, and it's drugs that do we actually know the true mechanism of action of anesthesia at this point?
That's a really good question. The answer is not necessarily. So for most of the injectable drugs, we know basically how they work. So we know how ketamine works and we know how propofol works. But the inhalant anesthetics, isoflurane and sevoflurane, we still do not know how they produce anesthesia. Interesting, isn't it? Drugs we use all day, every day, and yet we don't know how they work.
What's your favorite drug?
Oh,
legally provided, documented, everything.
Yeah, he means for anesthesia, I think, right?
Yes.
So, yeah, excellent. That's a really tough question because anesthesia, my usual, I can't give one answer. I have to give three.
I was going to say, is it a concoction? If it's a concoction,
yeah, absolutely.
then that's fine. Yeah.
Because anesthesia is not just one phase, and in fact, really there's 4 phases of anesthesia. There's pre-medication, so we need to choose some sedative and analgesic drugs. Then there's induction, so we need to now have a different drug class. Maintenance is usually an inhalant, and then recovery is also equally important, and sometimes we need to readdress sedation or analgesia, or sometimes we need to reverse drugs. So in the first category, pre-medicans, the opioids are always very useful. They're good analgesics and they're sedating in dogs. And we usually combine those drugs with a sedative like an alpha-2 agonist like dexdomitor. For induction, we have really quick-acting drugs like propofol, which is really nice to titrate to effect. We also have ketamine, which is a longer duration induction drug, and it also has a lot of nice attributes.
So you like using ketamine?
I like ketamine, and I know there's some people that they feel like ketamine's an old drug, and it is old, but it just gets better with time. So ketamine, it causes minimal cardiovascular respiratory changes,
yes.
and so it's actually quite a safe drug. The difference between it and propofol is it doesn't act as quickly, so it's harder to titrate to effect. And it does require metabolism by the liver and the kidney, and propofol does as well, but it's metabolized by a lot of other mechanisms too. So ketamine, if the patient had renal or liver issues, it's a little bit harder to clear ketamine, but it's an excellent drug.
And are you using it alone or are you using it, the Ket-Val? Are you doing the Ket-Val?
Yeah, absolutely. So ketamine with a benzodiazepine like Valium or midazolam, because ketamine does not have good muscle relaxation. So the patients can be a little bit rigid if you don't have a muscle relaxant. But yeah,
and they wake up like this.
And they do. Yep, watching that tennis match. And you know, ketamine's changed a lot. So anybody out there that used to use ketamine and ketamine has not changed a lot. The dosing has changed a lot.
Yes.
So if you used to use ketamine and you got scared because maybe you didn't like those recoveries or you had some bad effects, remember, I can say this, back when I graduated from vet school, I thought I'd never say that, but we used to give cats 1 cc of ketamine and a hub of ACE, and yeah, we had some adverse events, and that's absolutely the wrong dose. The dose for a cat would normally about 0.2 of a cc plus alpha-2 agonists or opioids or both, but it's a big difference, and so if you got afraid of ketamine, come back and use a different dose. Then my next phase of anesthesia, the inhalants are definitely the easiest for maintenance. And then the recovery phase, again, just readdressing the opioids. So I have favorites from every phase of anesthesia.
Well, that's interesting about ketamine, because so my career started with Telazol injectable.
Right, yeah.
Only.
Okay.
But we'll leave it at that.
All right,
and
yeah.
then ketamine, Ket-Val was my favorite combo. Then propofol came in. It's just like, so for you, if you don't know, propofol is that Michael Jackson drug, but the difference is that when we give it, someone actually monitors whether the pet's breathing or not,
right.
and that's the significant difference.
And we don't give it at home.
No,
it's in the clinic.
we don't let anyone. We don't let the pet turn it on and give it themselves. There's no way. So I think there's, you know, part of a successful anesthesia is proper use of the drugs, not only dosing to effect, but proper use of the drugs. But let me ask you about isoflurane versus sevoflurane, because I get different answers all the time.
Well, let me give you yet a different one then.
Okay.
We don't want to make this easy. Physiologically, the changes that the inhalants cause physiologically are very, very similar. And the inhalants are potent cardiovascular and respiratory depressants, and that's why we want to pre-medicate and use pain management drugs. We want to keep the inhalants at as low a dose as possible. That's the safest way to do anesthesia. And so we keep the dose low to minimize the respiratory and cardiovascular effects. And they're the same, really, with sevoflurane and isoflurane. What makes sevoflurane different is it's a faster acting inhalant. So it is easier to kind of titrate it to effect like propofol. You can really change the anesthetic depth almost breath by breath. And so sometimes in critical patients where that's necessary, sevoflurane can be used in a safer manner. I'm not saying it's a safer drug. You have to do it. And if you need patients to recover quickly, sevoflurane is a little bit faster. So, for instance, cesarean sections, I really like the moms awake and feeding the pups or kittens. It is more expensive, and so for me, if it's a medical reason that I'm ready to pass that cost on to the client, like a C-section, then it's a good choice. For most of our general procedures, isoflurane is absolutely fine. We don't need that quick response. And especially, for instance, like orthopedic procedures, where we use a lot of analgesic drugs and a lot of pre-medicants, you might not even see that difference with the inhalant.
Okay.
The real bottom line is monitoring anesthetic depth, and so whether they're senior and sick or healthy, the monitoring would be key, but I think that's a fair division between the inhalants.
And the big difference for you out there in your veterinary teams is it goes up to 8 versus 5.
Right. The dose, if you will, of the inhalant of sevoflurane is about double of isoflurane, so that vaporizer is going to scare you right at first. And if you kept an isoflurane vaporizer at 4%, you'd be into big trouble very quickly, but 4% on sevoflurane is about average.
That's
so
maintenance. That's the biggest thing I get when I get new team members and they see that, they go, I go, this goes up to 8.
Whoa.
It's like the spinal tap. This goes up to 11, right? It's you just got to get used to doing it. What's your take on buprenex?
Excellent addition to your pain management repertoire, if you will. Remember, it's called a partial agonist opioid, so it's not as potent as morphine or hydromorphone or methadone or fentanyl because it only partially activates that mu receptor. But it has a longer duration, probably 4 to 6 hours. We used to say 8 to 12, and now we doubt that it lasts that long, unless the pain is really mild. If you send it home as a BID drug and it's really mild pain, then that's probably all right. Otherwise, it needs to be administered more often or as part of multimodal analgesia with an NSAID. It can be administered transmucosally too, so it's absorbed on the oral mucosa.
Yeah, we do that. We send it home with cats.
Yeah, it's a nice way to send it home with cats. You could do it with dogs too, but it's a big volume and a bigger dog and not very cost effective. In really small dogs, it works. One change with that, though, is we used to think that the absorption from the oral mucosa was just as good as injecting the drug. The bioavailability was the same. And recent studies have showed that that's actually not true. So if you see it not working in your patients when you send it home that way, don't be afraid to increase the dose.
Okay, so I got to ask, what's your oral dose? What's your standard oral dosing range then?
So I usually use 0.03 milligrams per kilogram transmucosally, somewhere between 0.02 all the way up to 0.05 if they're really painful. I mean, that's definitely a very painful patient. The good thing is if it's a little bit high, the dose, what you would see is sedation, so you can tell the owner to back off, so you're not getting the patient into any trouble. But normally about 0.02 to 0.03 by the time you send them home. We used to do 0.01 to 0.02, and that may not be enough in every patient.
We do 0.02.
Oh, excellent.
Yeah, I'm called the doper upper though, because that's the dose I do. But
you're right.
Okay.
It should be higher because the absorption is not quite as good. There's also a very special buprenorphine that's made specifically for cats, and it's FDA approved for cats, and very few drugs are. And that's the 24-hour duration buprenorphine called Symbidol. So we utilize that a lot as well.
And that can be used orally as well?
It can be.
Yep.
The subcutaneous injection is so easy to administer that we still just give it subcutaneously.
Okay.
There's only one study using it transmucosally, and it only lasted 12 hours instead of 24, but they gave half the dose. Don't ask me why. So you would expect half the dose to last half as long.
Peer-reviewed journals.
Yeah.
Okay.
Right?
No, but that's good to know, because I've been a little leery about going to that longer acting one, but
it's a nice drug. For veterinarians out there and veterinary technicians, occasionally we get cats that are a little bit more sedate than we'd like for 24 hours. And to be honest with you, all of you, I'm using about 3/4 of the label dose in most of my patients. That label dose is based on using the drug alone for pain relief, which is what the FDA requires. So perfect reason to put that dose on the label, but that's not the way we practice pain management. We use multimodal analgesia, as you said. Maybe the patients had local blocks or NSAIDs, so you don't need that full dose. And if the cat's really sick or true geriatric, where it's showing signs of being a geriatric, I've even gone as low as a half dose. I don't have a paper to show you that's effective at that dose, but I would expect it to be in those patients because we'd use a lower dose of
Well, you're getting reports back from the
hydromorphone.
clients that it's working, right?
Right, exactly, right. Always communication with the clients.
And final question before we take a break is, have you ever seen buprenorphine reactions where the cat gets like wild or psychotic? 'Cause is that a myth or is that a reality?
You know, it can always happen. Opioids are excitatory in cats. They're less excitatory in painful animals. A lot of the research shows excitement in cats, but it was done in non-painful cats. So we're giving it because of pain, so less likely to happen. Buprenorphine even less likely than some of our potent opioids like morphine or hydromorphone, but they're cats and it's an opioid. If it happens, sedate the cat, let the opioid wear off a little bit, or reverse the opioid.
Okay, great. Let's take a break with that. That's a lot of information. That's a lot of veterinary information, but it's great information.